Hi future doctor, my name's Alex and this is the high yield science lesson for the endocrine system. You'll see here that we'll be using one particular hypothalamus, anterior pituitary endocrine axis, but really this whole lesson is a great vessel for the discussion of all axes and typical feedback mechanisms. With that being said, let's jump right into our learning goals. As we just said, we'll be using one axis in particular, the HPA axis. So after this lesson, you'll be able to describe its functioning and also contrast the effects of the different conditions that affect it. Take a minute to read this question stem now. Besides talking about all the downsides of having Cushing syndrome, the first paragraph doesn't tell us much more than what treatment is most optimal in resolving some symptoms. The second paragraph is much more insightful. Not only does it tell us about 3 endogenous mechanisms that can cause Cushing syndrome, but it also tells us about a certain patient who shows certain symptoms associated with Cushing syndrome. This is our chance to play doctor and reach a diagnosis based on the information that we're given. As you've just seen, the MCAT might talk about diseases and treatments you've never studied before. You might be asked to use your background content knowledge to make sense of those diseases based on their treatments. And that's exactly what we're preparing for right here. We're told in the question stem that depression in Cushing patients can be resolved rather quickly by administration of glucocorticoid receptor blockers. So let's go through the HPA axis and find the glucocorticoid. Starting at the top, the hypothalamus is going to release corticotropin releasing factor, also known as CRF. And as in most hypothalamus anterior pituitary endocrine axes, the hypothalamus hormone is going to stimulate the release of its respective anterior pituitary hormone. In this case, we're looking at ACTH. That's what the plus sign on the arrow indicates. Once ACTH is released, it's going to act on the adrenal cortex to stimulate the release of cortisol. Of these 3, cortisol is our glucocorticoid. What does the word glucocorticoid tell you about cortisol? It's actually pretty insightful. Not only does it tell you that cortisol changes glucose handling, but it also tells you that it's made from the cortex of the adrenal glands, hence the corti portion of the word. So we were able to infer that high levels of cortisol are always responsible for any type of Cushing syndrome. But in the question stem, we're told about 3 different conditions that all lead to Cushing syndrome. They're indicated with boxes on this figure. We have a pituitary adenoma, adrenal cortex adenoma, or ectopic tumor. Anytime you're dealing with a tumor, you're looking at overgrowth, overproduction, basically over everything of the impacted area. So if an area normally makes a hormone and there's a tumor in that area, then you'd expect a lot of that hormone. Then it's pretty straightforward how an adrenal cortex adenoma will contribute to Cushing syndrome. That adenoma would make a whole bunch of cortisol, leading directly to Cushing syndrome. How does an anterior pituitary adenoma cause Cushing syndrome then? Well, lots of ACTH means lots of stimulation on the adrenal glands means a lot of cortisol. A reminder, high levels of ACTH is not in itself responsible for Cushing syndrome. High levels of cortisol are. Finally, why is it that something that's ectopic or outside the HPA axis can cause Cushing syndrome? If you have ACTH, no matter where it's from, no matter if it's made from where it's supposed to be made, it's going to stimulate the release of cortisol. So this is how all of these different problem areas can all lead to the same syndrome through feedback mechanisms. Now that we understand the fundamental characteristic of Cushing syndrome, we can start a differential diagnosis to find out what our patient is suffering from. We're told in the question stem that the physician might look for hyperpigmentation. What does that tell us in terms of how often the symptom shows in Cushing patients? This gives us great insight right off the bat that not all Cushing syndrome cases are associated with hyperpigmentation. Because of this, it's worthwhile both to understand what causes hyperpigmentation and to use that symptom to shed light on the patient's condition. In order to make sense of hyperpigmentation, we're going to contrast 2 of the conditions we've seen earlier on. Let's start at the top with our anterior pituitary adenoma. In this figure, the square still indicates the problem area, and that's where we'll start. We just established that tumors are associated with overgrowth, overproduction, over everything. So our impacted anterior pituitary here is going to produce ACTH, and it's going to produce a whole lot of it. That's what the 3 plus signs indicate. Because there's a lot of circulating ACTH, there's going to be a very strong stimulation on the adrenal glands, which means there's going to be a whole bunch of cortisol that's going to be secreted. We haven't yet considered how cortisol feeds back on the hypothalamus and the anterior pituitary, but based on your prior knowledge of hypothalamus, anterior pituitary, and organ axes, how will cortisol feed back on the brain? It's going to have a negative feedback. The whole point of the HPA axis is to make cortisol, which ultimately exerts the end effect. So when we do make cortisol and we are carrying out the effect we want to carry out, we need to tell the brain, hey, This happened, we're all good now, you can stop making cortisol. That's what the negative feedback is for. And here, because once again there's a lot of cortisol, there's going to be a strong negative feedback, which is what the three negative signs indicate. We have an anterior pituitary adenoma and we have a strong negative feedback from cortisol. What will our CRF levels look like in this particular case? They will be extremely low because the anterior pituitary adenoma only affects the pituitary, not the hypothalamus. So the hypothalamus is normal as far as it's concerned. There's a lot of cortisol, so it stops making CRF. But what about the anterior pituitary then? Is it going to respond to cortisol's negative feedback? Not really. We have a big tumor here, and those don't tend to care a whole bunch about their surroundings, so it's just going to keep making a whole bunch of ACTH. So if we look overall at our HPA hormone levels in this type of adenoma, we would have low levels of CRF, high levels of ACTH, and high levels of cortisol. Shifting gears now to our adrenal cortex adenoma. Let's use the same technique as before, which is to look at our problem area first. Adrenal cortex adenoma makes lots of cortisol. Will the feedback exerted by cortisol made from a tumor change from the negative feedback we saw above? Absolutely not. It's cortisol, no matter where it's from, it exerts the same feedback. So here it is, 3 negative signs because of the strong negative feedback because there's a lot of cortisol. Perfect. The brain here is in excellent condition, so a strong negative feedback by cortisol will lead to extremely low levels of both CRF and ACTH. So if we look overall at our hormone levels in an adenoma of the adrenal cortex, we would see low levels of both CRF and ACTH and high levels of cortisol. If, as we said earlier, hyperpigmentation does not appear in all cases of Cushing syndrome, then what can we infer about the hormone responsible for hyperpigmentation? It has to be the one which doesn't show the same trend across the two conditions. Because in both tumors here, CRF levels are low and cortisol levels are high, the only hormone that can be responsible for hyperpigmentation is ACTH. In terms of why high levels in particular, as opposed to low levels, cause hyperpigmentation is outside the scope of the MCAT. In short, ACTH breaks down to MSH, which stimulates melanocytes to make melanin. So our patient is said to be exhibiting hyperpigmentation. What condition or conditions does this allow us to rule out for a patient? It allows us to rule out the adenoma of the adrenal cortex. This really leaves us with two alternatives to our patient. He's either suffering from an anterior pituitary adenoma or an ectopic source of ACTH. And we're going to use dexamethasone to get to the bottom of this. Before we do, let's consider what we already know about our feedback mechanisms. A lot of ACTH, regardless of its source, is going to strongly stimulate the adrenal glands to release cortisol. We know this. But what are we told about dexamethasone? It's a cortisol analog. It means that it's going to mimic cortisol and exert the same feedback effects. With that in mind, dexamethasone is going to exert a negative feedback on the anterior pituitary. That being said, what effect will dexamethasone have on an ectopic source of ACTH and why? The first thing you should have thought about when answering this question is, well, what allows cortisol, or any other hormone for that matter, to exert its feedback effects? Ultimately, you should realize that the cortisol receptors are what allow for cortisol's feedback. Where you have receptors, you can have feedback action, and where there aren't, you can't. So then you turn your attention to the ectopic ACTH secreting adenoma and you ask yourself whether it should have cortisol receptors. As we've said a few times throughout this lesson, this ectopic source is totally outside the HPA axis. In other words, it's not supposed to be responsive to cortisol. Molecularly, this translates into our ectopic source of ACTH not having cortisol receptors. Therefore, dexamethasone will not have any impact on how much ACTH is released from the ectopic source. At this point, you might be thinking, wait a minute, didn't we say earlier on that the tumor doesn't really care about our feedback mechanisms? We absolutely did, and that's true. But the anterior pituitary adenoma, being anterior pituitary tissue, will still carry some cortisol receptors. So a very high dose of dexamethasone will make ACTH levels dip just a little bit in the case of an anterior pituitary adenoma, but will have zero effect on ACTH levels if ACTH is made from an ectopic source. And the nice thing is that the dip is significant enough to where dexamethasone administration will allow to tell between an anterior pituitary tumor or an ectopic tumor. To bring this home, in the question stem, we're told our patient is unresponsive to dexamethasone. This allows us to eliminate the anterior pituitary adenoma as our potential diagnosis, leaving us with the ectopic source of ACTH as the only remaining option. Therefore, this has to be our final diagnosis. During this lesson, we focused on the HPA axis. We explored its functioning, explored its feedback mechanisms, and we also considered three conditions that affected that axis. There are really two big takeaways from this particular lesson. First, expect conditions, diseases, technology, experiments you've never heard about before reading about them on the MCAT. That's okay. Keep cool, extract the information that you need, supplement it with the information that you know, and get those points. Second, the HPA axis is a typical hypothalamus anterior pituitary end organ axis. I know you're tired of me saying this, but it's so true. If you understand why the feedback mechanisms exist where they do, then you've already understood 90% of all the other axes.